Hello, everyone, and thank you so much for joining us at this webinar on charting a course for upstream community health investments. I want to let you know just before we get started that we will be recording this webinar, and we will be sending you and all registrants a copy of the recording once the webinar has concluded. I'm Grace Rubenstein with HealthBegins, and I am here today with Rishi Manchanda, President and Founder of HealthBegins, and Mark Gamble, Senior Vice President and COO of the Hospital Association of Southern California. We are going to be keeping participants on mute today, but we are really interested in hearing your questions, so we encourage you to use the question pane that you'll find at the side of your GoToWebinar screen. And before we get started, I'm going to give Mark a moment here just to introduce himself to all of you. Mark?
Good morning, everybody, or afternoon, depending on where you are. Mark Gamble, as I was introduced, I'm the COO here at the Hospital Association of Southern California, and also Senior VP of Association Services. And about 18 months ago, we launched an organization called Communities Lifting Communities, which you'll hear about shortly. I've been with the association for 24 years now in all sorts of roles, and I'll tell you where I am right now and involved with Communities Lifting Communities and working with Rishi and his team, the highlight of my career so far. So this has really been great. I look forward to sharing more about it with you in a little bit. Thank you, Grace.
Oh, that's good to hear, Mark. Thank you so much. So this is a 1-hour presentation. We will be reserving time at the end for questions. And again, please do use that question pane at the right-hand side of your screen. With that, I will let Rishi get us started.
Thank you, Grace. And hi, everybody. And Mark, thanks for joining us today. It's really great to have the Hospital Association of Southern California on the line with us today. And thanks to all of you for jumping in today in the midst of your busy morning or afternoon. My name is Rishi Manchanda. I'm the president of HealthBegins, and today's webinar is really the first in what we hope is a series of conversations about how to optimize upstream community health investments with an audience specifically in mind of those involved in community benefits and population health within hospitals and large health systems, and of course, most importantly, their partners in the community. So if that resonates with those of you on the line, we're hoping that today's webinar is of interest and really looking forward to your dialogue and questions towards the end of the webinar. So with that, let's dive right in. Today's learning objectives are to first help all attendees be able to identify key aspects of the Hospital Association of Southern California's community health investment strategy, which Mark will speak to in a few moments. Second, we want to make sure that you all feel comfortable being able to list a few major strategic challenges facing hospitals that seek to optimize community health investments. We're sure that many of you have really strong ideas and clear ideas about some of the barriers that exist. We also would like to share with you today the Upstream Strategy Compass and allow attendees at the end of this webinar to be able to describe the Upstream Strategy Compass, which is an approach that HealthBegins has developed to help your community health investment strategy further develop and be refined. So with that, looking forward to just giving you a little bit more information on why we're here today to set the stage before we tell you about who we are and what we're doing. So why do we need to chart a course upstream? I think for many of you, this is self-evident, but it's worth unpacking this. From our perspective, I think it's clear to many, including those of us at HealthBegins, that population health is increasingly becoming a core part of the mission of hospitals and of clinics, driven particularly because of this drive towards value away from volume. We know that investing in the communities that surround these hospitals and clinics can be a really key part of improving population health. We know this is not new to many hospitals, of course, through community benefits work especially, and in other forms of population health investments. Hospitals have long been engaged in this work in different ways. But I know that this work is now ramping up because of the shift in the space. And our perspective is that setting up smarter priorities and building stronger partnerships to advance this mission really requires a focus on the complexities of this work, right? This is a complex challenge. So setting up smart priorities and strong partnerships is still a really complex challenge here. How do we do this? So to really ground us all in terms of who's on the line today, as part of this dialogue, we wanted to introduce the first poll question. So the first poll question is, we'll launch in a minute. question is, in which type of organization or department do you spend the majority of your time? I'll give it a few more seconds here. Are you a hospital community benefit department based leader or staff member? Are you working in population health or value-based care primarily? Are you in performance improvement and quality improvement work, etc.? I think we'll be able to see the results. Great, so it looks like we have a good third of folks who are other, but a smattering of folks belonging to hospital community benefits departments in the PI and QI space, but a bulk of folks who are either with community-based organizations or in the population health space within your hospitals or health systems. So with that, we'll go back to the presentation here and ask another question. What are the top 2 drivers motivating your organization to address social determinants of health? And we'll turn on this poll. One driver are the value-based payments and contracts that you may be engaged with. In other words, we will be paid to do this work. That's why we address social determinants. B, regulatory requirements are your major drivers. Another way to put that is that we are being told to do this. C, organizational leadership and culture. And the shorthand for that is, if not us, then who will do this? Or D, other. And let's go ahead and see the results. Well, this is really interesting. So it appears that a lot of the folks, and perhaps not surprising based on the selection bias that this webinar represents, but a lot of the folks who are on this line are indicating that organizational leadership and culture really are driving you to address social determinants, followed with the shift towards value-based payments. A small number of you are talking about regulatory requirements, and perhaps in some dialogue at the end of this webinar, we can understand the other reasons, the other drivers that are driving this. So that's really helpful just to understand who's on the line and what we consider to be the main drivers of our work, especially for those of us at HealthBegins who are deeply engaged in this work in settings across the country with a host of different partners. Our mission really is to improve care and the social determinants of health by making clinical community partnerships more effective and efficient. We're privileged to really be working with a whole variety of stakeholders that are described at the bottom, including work we're doing with the CMS Accountable Health Communities model as a TA provider for that network. This is a busy slide, but it gives you a sense of the busy work that's out there to address these multiple challenges that I think many of you may attest to. When it comes to building these clinical and community partnerships, there are a number of implementation challenges, and you can read the list here on the left, but suffice to say that HealthBegins' work really is about providing advisory and training services to address each of these different challenges, and we often provide those services by leveraging the tools that we've built, including the ones listed on the right of this table. Today we'll be focusing on the first one at the top right, the Upstream Strategy Compass, as a tool to be able to help develop cross-sector population health strategies. A little bit about the kind of core tenet of our work, which is that we really track with the quadruple aim, especially in, of course, the healthcare organizations. So looking at patient experience, looking at outcomes of populations, looking at how to lower per capita total cost of care, as well as the experience of the healthcare professionals in these systems. Now, this is relevant not only for healthcare, but for other organizations in the community as well. But we're also really mindful of, at HealthBegins, especially the broader questions of equity, both as they apply to each of these aims for our organizations, but also to the broader context of what's happening outside the walls of healthcare and other community organizations. Questions of opportunity, of decision-making, structural fairness, racism, sexism, all these things are, of course, pressing issues of equity that we really consider deeply. And what we've learned and what animates us really is that part of the solution to achieve the quadruple aim has to be the integration of social determinants into our work. The clinical community partnerships are required actually to be able to help achieve the quadruple aim and to advance equity. And if when we don't do that, then we actually miss an opportunity to advance the quadruple aim and advance equity and justice in society. So with that, I want to turn the baton over to Mark. Mark, this is really an opportunity for all of us to hear about some of the really innovative and bold leadership that the Hospital Association of Southern California has been taking, especially in the past year. So, Mark, it's all you.
Great, thanks, Rishi. And Grace, if you can go to the next slide, I'll start talking from there. So, the Hospital Association of Southern California, we represent 184 hospitals in 6 counties in Southern California, which has a population of over 12 million people. It's not a consolidated market. We still have a lot of independent or small systems. We also have some very large systems here, and we have a handful of freestanding hospitals as well. So hospitals range in size from Cedars-Sinai down to Bear Valley up in Big Bear, which has 4 beds and a SNF associated with it. And so, as I said, I've been here for 24 years, and the community benefit law has been on the books in California for quite some time. In communities lifting communities is rooted in a conversation that took place between 2 hospital system executives and a CEO from a foundation, and they were talking about how much money their organizations are spending on community benefit, yet they really can't show that they've had an impact, or we've had an impact here in Southern California on addressing the social determinants of health. So that led to a meeting with a number of other hospital system execs and the hospital associations, or hospital association, and they asked us to see if we could lead an effort to transition from a community benefit mentality and structure to more of a community health improvement, and really see if we can move the needle on community health improvement. So that's where the roots from Communities Lifting Communities comes from. It is a partnership between another organization called HC2 Strategies and the Public Health Alliance, which represents 7 of the 8 public health directors here in Southern California. And then through that process, we formed about a 15-20 member board that's represented by, we have Medicaid managed care plan CEO on that. We have medical groups. We have community-based organizations involved, and we also have the community clinics, along with a number of hospital executives as well. And then through that process, I was introduced to HealthBegins and Rishi Manchanda, and he's been played a critical role with us as we've developed our communities, our structure and focus areas. So if you go to the next slide, Grace. Through the process of doing interviews and talking to our members, and also public health, and also we conducted a study with HMA, Health Management Associates, about the homeless issue here in Southern California. We chose 3 focus areas for Communities Lifting Communities to really try and tackle over the next couple of years and beyond. The first one is diabetes, as you can see. Second one, homelessness. And then the preterm birth outcomes or disparities in the African American community, that's contained pretty much in Los Angeles County, but we believe the learnings from a pilot that I'll talk about in a little bit will be able to be replicated and spread elsewhere. And so we're very excited about that as well. And there's already in Southern California numerous collaboratives and entities that are tackling social determinants of health and trying to reduce health disparities. And so we aren't trying to insert ourselves in a leadership role in all these aspects. So we've taken on 3 different roles. We have 3 different roles within Communities Lifting Communities. The first one is to lead, because there are some areas of what we want to do that really don't have a leader or a driver behind them. And so we will take more of a leadership role. And then others where there are established collaboratives or established organizations that are really pushing and doing and making some good progress, we will partner with them. And then in other areas where there are real drivers, we will just support what they are doing. So that's really what we're going to be focusing on. And in the next slide, you'll see a map of our region. And we really just got started with funding. The funding structure here is is the hospitals, the members of HASC have agreed to help support the startup of Communities Lifting Communities. And in addition to that, we've gone out to the foundations, the usual players in that space, and are seeking additional funding to start with the initiatives that you see on that graph. The two that I will call out for purposes of this webinar are the diabetes pilots. There is one in Ventura County and then another one in Long Beach. Long Beach, the city of Long Beach has its own public health department within LA County. That's somewhat unique here. Pasadena as well, another city that has a public health department. And we're going to focus on those diabetes pilots because we can take a leadership role in helping those public health departments and the hospitals that are in those regions, we believe, make a big impact on diabetes in those regions. And then you see we also are going to be supporting existing efforts that are taking place in the inland area, which are Riverside, San Bernardino County. There's a lot of work being done in Orange County around housing, homeless services, and mental health. And then I mentioned the preterm birth pilots. And then the coordinated entry system pilot that you see there, that's something that LA County Department of Health Services has implemented to get the homeless individuals into a coordinated entry system so we can have a better success rate at getting them to permanent supportive housing. And then in Santa Barbara, again, it's a support role for their existing food insecurity and housing instability efforts that they have ongoing in that area.
Mark, pardon the interruption.
That,
we have a
yep.
question looking for clarification on that previous slide, asking whether the focus areas and roles are meant to be aligned by number, or do all the roles apply to all three focus areas?
All the roles. Yep. Very good question. Thank you. And as you ask that question, it becomes obvious that could be. I can see where that comes from. So those numbers, they do not correspond. So we will be having a leadership role we'll be doing the three roles in each of those three focus areas. So there are some aspects of the things that are going on with diabetes that we will be in a supportive role, such as what's happening out in the inland area. And then, as I mentioned, in Ventura County, we'll be taking a leadership role or co-leadership role with public health. Thank you, Grace. Any other questions have come up since then?
That's it for the time being, but I will keep you posted.
Thank you much. Okay, and then at the bottom of, or in that green box there, you see a description of what we're doing throughout our region. One of the things that we've learned recently that's going on, and so we'll be starting soon in Santa Barbara, are the hospitals up there are going to be using a social needs screening tool to screen for transportation, behavioral health, housing instability, and food insecurity. And originally they were going to start at the patient level, but then they realized they should also do that screening for hospital employees, because there's a big group of hospital employees that are in food services or dietary and the services area that we think we can have an impact in their lives as well. And that'll be a voluntary effort that we undertake in terms of the social needs screening tools. We're also developing a hospital leadership and board governance education program, and we're very close to having a relationship with an organization called the Hospital Quality Institute here in California that will be collecting some very robust data that we believe we can overlay on public health to give us a better indication of where the hotspots are for addressing health disparities. And then, of course, as all associations do, we're going to have a role in advocacy as well. And then one of the things that our board, the Hospital Association board, told us as we were presenting this to them in February was, you all need to come up with a way to make this sustainable. And we have to find some innovative financing in order to make this work, not just be the collaborative of the year or the effort of the month. we've got to find a way to make this a sustainable effort to address health disparities. And it's really going to be driven by, I think, the move to value-based payments. And that's why we have, I think, now some attention, not just from the not-for-profit hospitals. It's also important for me to point out that our for-profit hospitals and systems have said they want to participate in this, because for them, it is also important that they see an improvement in health disparities in their community and a reduction of the social determinants of health. So that next slide, Grace, and the last slide for me is, as I said, we've been working with Rishi and HealthBegins early on, and something you'll see in later in the webinar is what we call the 3x3 grid. He now has a name called the Upstream Strategy Compass. When we first saw that, our name for it was Rishi's really cool grid. And we're going to now be implementing that, and he'll be part of the diabetes pilots in Ventura and Long Beach, along with the Public Health Alliance. And that grid really allows us to identify what level of intervention and what organization is going to be the driver in that, and how far upstream do we go. Hospitals here are still, by and large, at the downstream point of service. I mean, it's obvious with the emergency departments, the problems and what they see in the emergency department is where they live every day. And we're getting them to think differently about moving more upstream to end the cycle of those that are homeless or those with diabetes that keep cycling through the emergency departments. So as you see in that grid, and you'll hear more about it in a little bit, the Upstream Strategy Compass is going to be instrumental in those pilots around diabetes. So that's a quick overview of where we are with communities lifting communities. I have two colleagues here I'd also like to acknowledge who have been pretty much with me from the start of this journey. It's Rishi Rasasamy, who is our fellow here and has been here for a year, and then Bethany Morton, who's been with the association for 18 months. And both of those have been instrumental in getting us where we are. So I need to acknowledge them. Even though you can't see them, they are here with me today. So thank you, Grace. And Rishi, I'll turn it back to you now.
Thanks, Mark, very much. It's so helpful to see how this work applies in the real world. We do have a couple other clarifications for you, if you can stay with us off mute for just a moment. One is, if you could just repeat the names of those collaborative organizations that you mentioned. And the other is, can you explain, please, how those focus areas were selected originally?
So the partner organizations within communities lifting communities, what we call the founding partners, HC2 Strategies, they're an organization, the two partners in that, Dora Barilla and Rick Rawson, are former hospital executives. Dora's been in the community benefit space for many, many years, and Rick is a former hospital CEO and CFO. And so as we started down this path, I reached out to Dora and Rick, and they helped us set up Communities Lifting Communities and put together our structure. And then shortly after we started this journey, we met the Public Health Alliance and Tracy Delaney and her team. The Public Health Alliance, as I mentioned briefly, represents 7 of the 8 public health departments or officers here in Southern California. And so this is very unique, we believe, where we bring public health officers and hospital executives and other community-based organizations into a room to try and come up with a strategy to tackle those 3 areas that I mentioned, or the focus areas, I should say. And then that leads into the how did we select those? Homelessness, for those of you that are near Southern California or that read the paper around the country, I think you know we have a significant problem with housing instability and people who do not have homes. Just in LA County alone, by last year's count, we have 57,000 homeless individuals. and we believe that number has increased since last year. They're just finishing up the count this year. The diabetes focus area, that came through a number of discussions with the public health officers, their staff, and also out of the community health needs assessments that were done by our not-for-profit hospitals here. And so that one, that and homelessness were kind of the low-hanging fruit, but the big fruit to tackle in terms of a focus areas. And then the preterm birth outcomes in the African American community, that was more at the invitation of LA County Department of Public Health. The Public Health Alliance was already working with the department on that, and we thought that was a great way to test change, a system of change in a small region that we can replicate in other areas, not just in Southern California, but take the learnings out and go to other areas where there's the significant issue of health disparities in the African American community around preterm birth. So that's how we came up with those focus areas. It was not scientific, but it just felt right, and we believe those are the three. And they also allow us to bridge into different areas. Diabetes obviously allows us to get into the food insecurity, homelessness. At least in Southern California, there's a large population of our homeless here that have behavioral and mental health. And so we are branching off into behavioral and mental health issues as well through Communities Lifting Communities.
All right, thanks for those clarifications.
You're welcome.
We do have more questions rolling in, which is great. Did you? Oh, one more thing. Go ahead.
No, I was just going to say we'll stay here throughout and be ready to answer questions at the end if there are any.
That's great. In fact, I think Rishi himself has one for you coming right up. And all the other folks on the line, please keep posting your questions in the questions pane. We're going to come back at the end and be able to delve in more detail into the work in Southern California. So now I will hand it to Rishi.
Grace, thank you. And Mark, thanks so much. I think this was incredibly helpful. And as Grace said, really helpful to get a grounding in what's happening in a particular region and the work that HASC has been doing along with its partners at the Public Health Alliance and with HC2 Strategies. I'm wondering, as we pivot now to talk about the Upstream Strategy Compass, to try to see how this may be applicable to other communities and other folks who are on the line today. Mark, if you could spend just one more minute really briefly just describing a couple of barriers that you think that members are facing, whether it's business case or operational know-how or kind of a buy-in. I'm curious if you could speak to one of the barriers and how CLC has helped you address those really quickly, because then I think we could turn it over to the audience. That might be a really nice segue for us.
Yep, I think there's two big barriers. That there are a lot of barriers, and I think one of them, and this isn't one that counts, so I'm going to give you a couple more, Rishi, but one of them is just the size and the scope of LA, or not LA, but Southern California in general, the geography and the population and the segmentation. But I think the big barriers that we're seeing here, one is the slow transition to value-based payments. So as you mentioned, the business case, the financial incentives are not aligned between hospitals, the Medicaid plans, and the groups necessarily to tackle this. There's also different nomenclature being used by public health in the hospital world. And as an aside, we had Rafi attended a meeting a couple of weeks ago with public health officers, and they were expressing frustration because they weren't able to connect with people in the hospital regarding homeless discharges. And then we had a hospital CEO meeting here, and they were saying their case managers and discharge planners were frustrated because they weren't able to connect with public health. So both sides want to work together, but there's just not the relationships haven't been established. So that's one of the things we'll be working to help make those links, those linkages that are missing. And then, as I said in my opening, that we do have the Medicaid managed care plans at the table, and we will look to them to work with our hospitals and the medical groups in aligning the incentives in terms of the financial to make the financial investment in this a business case.
Mark, thank you so much. Extremely helpful, and I think it's a perfect segue then to what we want to do in inviting others to kind of weigh in. Hopefully, in hearing from Mark about the work that HASCA is leading with its partners here in Southern California, others on the webinar today are thinking about their own experiences and progress. We wanted to actually invite you to share your barriers, building on what Mark just did, and identify the top 2 major barriers you're facing when it comes to improving your upstream community health investments. We'll go to launch the poll now. So when it comes to barriers, is it a lack of a clear business case? So in other words, how will this save or make money for us? Is it lack of operational know-how, which is, all right, how do we do this? Is it lack of buy-in from internal stakeholders? Like, what does this have to do with us, is the framing question there? Or is it a lack of effective partnerships? How do we work with each other? How do we work with them? Let's give it about 5 more seconds here. Great, and let's see the results of the poll. All right, well, the top 2 winners here, at least purely by the numbers, looks like we have a tie for second, but lack of a clear business case, building on Mark, I think what you mentioned clearly is a major barrier for a lot of folks, followed with a dead heat right now for second place with lack of operational know-how and lack of buy-in, with a close third with lack of effective partnerships. So it seems like there are barriers that are evenly spread, relatively evenly spread across the board, with a predominance for the question about the business case. That's a really good segue for us actually to talk about why it was so important, I think, both in our relationship with the folks at HASC and in our work across the country, working with other folks to think about the frameworks that are out there. How do we actually start to make sense of all these barriers in a way that motivates us to take action? In past webinars, you've heard us share the case study of Mrs. M to help ground us to take this on, and I'll do that again today quickly. So Mrs. M is a 46-year-old mother of 2. She is caring for her frail mother at her home as well. She's got jobs. She's managing multiple competing priorities, as well as managing her own diabetes, which is unfortunately not well controlled right now. At the end of the last month, she fell really ill at work. Her coworkers called the paramedics. She was escorted to the hospital and admitted. And the diagnosis after an exhaustive workup was hypoglycemia, low blood sugar. This is unfortunately a pretty common story, I think, for a lot of folks on the line, whether you're in the clinic or the community context. You know, this is a pretty common storyline. The root cause in this case, for this diabetic patient, for Mrs. M, the root cause of her hospital admission turns out was food insecurity, not questions of medication adherence in that conventional sense, or other or even biological causes like medication side effects or underlying infections or whatnot. In this case, it was a food insecurity that drove her admission. And we know that from the evidence that's amassing over the last few years, that lower income diabetic adults in particular have a higher, up to almost 30% higher rate of hospital admissions at the end of the month due to food insecurity compared to higher income diabetics. So I believe a lot of folks, especially those on the line today, will be familiar with, of course, the predominance of just in the research literature of this connection between diabetes and food insecurity. So the question really is then, what do we do about this? How do we reduce and prevent hospital admissions for patients like Mrs. M, while we advance the quadruple aim and what's missing here, while we try to promote equity? So how do we do this? How do we address those barriers that you just spoke to? From HealthBegins perspective, there's a stepwise approach, and here we'll just walk through these steps in a way that hopefully becomes easy to follow, but please do ask questions along the way, and at the end of this, we'll save about 10 minutes to be able to dive into some of your questions. So this is really for us about building capability and about capacity. This is not just about putting together one-off projects. And I think, Mark, as you said, it was not just about being the collaborative of the month or the effort of the week. This is really about changing our norms and our capabilities as healthcare and social sector allies, working together to be able to build a new ecosystem that is capable of providing care to the whole person and to the whole community. From that perspective, we need to build our capacity, right? We don't have those systems in place right now. So step one really begins with identifying a priority population, picking one priority population where you can use to start to improve outcomes and improve your partnership. In this example, we've already picked diabetics, but in our work using the Strategy Compass with other partners, this is really a key step to select one population to be able to make your progress. The other step here, which we've again in this case study already selected, is to identify at least one priority social determinant. In this case, it's food insecurity, which is a driver for the poor outcomes among patients like Mrs. M. But it can differ. Mark and the folks at HASC are working on diabetes, but they're also working on homelessness and working on poor birth outcomes. And each of those are linked to different social determinants of health. It's important to pick one from our perspective. And so in this case study, we've already picked them, and let's kind of dive into the next step here, which is to start to identify those barriers specifically for that population. Not a boil the ocean approach for all social determinants and all population problems, but really for that set of diabetics in this example, or for your own specific priority population, what are the barriers to be able to address a specific social determinant? From our perspective, there's a lot of different lenses that we can take, and there's a small but growing number of frameworks to be able to analyze this. The Pathways to Population Health framework is the latest one. That's one that we found to be quite helpful in some regards, and definitely recommend it to folks who are looking for frameworks. An additional framework that we're talking about today is the Upstream Strategy Compass, and that starts with understanding that stakeholder priorities often differ by levels of prevention. Primary prevention to prevent the onset of disease, secondary prevention to help detect disease in its early stages and prevent its progression, and then tertiary prevention to be able to arrest the progress of an established condition and to control its negative consequences. So let's give us some examples of what this looks like when it comes to social determinants of health, especially for Mrs. M and diabetes and food insecurity. So what are some of the barriers when it comes to primary prevention? We know in some communities, and perhaps in many communities around the country, that one primary prevention barrier is overconsumption of trans fats and refined grain products, especially those with added sugar, and that this is particularly burdensome for low-income families who often have limited choices. Another barrier at the secondary prevention level is just poor access to healthy, affordable food for employees with prediabetes, right? In your own organization, for instance, folks with prediabetes may themselves have poor access to healthy food. There's also tertiary prevention for those who already have diabetes and severe diabetes. And one barrier there is the lack of tailored food or income support for those patients, particularly tied to reducing utilizations. Well, with those barriers in mind, we can, of course, start to identify particular solutions. A primary prevention solution for the first barrier would be, for example, to support a ban on trans fats or to create some policy changes to reduce the consumption of refined grain products with added sugar relative to something else. Secondary prevention solution may be to implement changes for your own employees in your organization to incorporate the DPP, the Diabetes Prevention Plan, to subsidize vouchers to farmers markets, and so on. And then the solution for the tertiary prevention category would be to reduce hospital use using medically tailored meals. Here in California and in other regions around the country, there is a large emphasis now on looking at the ability to have food itself be medicine, with large pilots now underway to demonstrate this might be an effective intervention as a tertiary prevention solution. So levels of prevention can be a helpful analysis to identify not just barriers, but also solutions. But we also know, working with stakeholders, that priorities differ not just by prevention, but by level of intervention. So in any given community, for example, here in Southern California and your own particular community, stakeholders differ in terms of where they focus their interventions. There are those on the left of this grid here who focus on the individuals, the beneficiaries like patients or clients. There are those who work at the organizational level, looking at how to engage stakeholders of an organization like employees or vendors, buyers, partners, and investors. And then there's those who work at a community level, looking at entire communities across largely geography, zip codes, cities. This is often the work, of course, of public health departments and of policymakers. Here's some examples, just like we did before with levels of prevention, to kind of drive this point home about what we mean by differing levels of intervention and how those inform different stakeholders. So barriers on a patient level, for instance, may be that there's limited screening for food insecurity among pre-diabetic and diabetic patients. That's a barrier that may be particularly relevant for patients like Mrs. M, especially earlier in her disease course before she became a diabetic. There may have been limited opportunities to screen for food insecurity. For organizations, physical spaces and organizational policies may not be conducive for healthy activity or eating for all employees. Mark made a reference to a hospital system in Santa Barbara, a member of their association, that is not just starting to screen and address food insecurity for its patients, but is also now piloting that work for its own employees. That's a great example of an organization level intervention. And then there's a community level intervention looking at policy barriers to limit access to that limit access to WIC and other food support programs among diabetic families in order to avoid food insecurity. There's a lot of barriers and again, corresponding solutions that may already exist or might be desired in particular communities that clinical and community partners can pursue together. So for example, for limited screening for pre-diabetic and diabetic patients, well, this may be a chance to implement those screening. And a lot of systems that we're working with, including many of you perhaps, are engaged in exactly this work right now, providing screening for the high need, high cost patients, especially with diabetes. There are other organization level interventions that are listed there to address that barrier. And then of course, policy solutions as well to address the barrier there. So we can slice it by prevention or we can slice it by intervention. What we found is that it's not one or the other, but it's a complement of these two that can be helpful. But before we kind of synthesize this, we wanted to understand your own experiences. Here's another kind of poll to keep you engaged and get your input here. What level of intervention do most of your organization's social determinants related activities belong to? So are they mostly individual level interventions, looking at patients or clients, organization level interventions, for example, screening your employees, or community level interventions where you're supporting local policy efforts to improve access to social supports, for example? Keep it open for another 5 seconds. All right, let's see what we have here. All right, so the majority of folks on the line are looking at the individual level, which is, speaking as a primary care physician myself, and given the stakeholders that we work with in HealthBegins, this is a really consistent with what we're seeing a lot. A lot of our partners work at this level. Some of you, 11%, work at the organization level predominantly, and then a full third of folks on the line are looking at the community level. This is a really great representation to ground us as we move to the next slide. Because in the next slide, what we're seeing is, again, that synthesis of how we, with the strategy compass, the Upstream Strategy Compass, what Mark referred to as the 3x3, how we bring this together to be able to take a stepwise approach now to do some planning and to take a methodical approach to addressing those barriers that stymie us from making upstream progress. So step one, let's identify those barriers. Let's identify the barriers not for a generic population, but for that specific population, the diabetic populations like Mrs. M. And let's identify barriers not just for all social determinants, but for a specific one, in this case, food insecurity. And if we can do that, let's now start doing this across different levels of prevention and across different levels of intervention. And you can see some of the examples that were presented just a few moments ago represented again here. You recognize these are all different barriers that, as an illustrative example, could exist not just here in Southern California, where we're working with Mark and the team at HASC, but in other regions where you might be working. That's step one, mapping out the current barriers along this grid of intervention and prevention. And once those barriers are mapped, how do you identify potential solutions to improve care and social determinants at the same time? For a lot of folks, it sounds like we're asking you to walk and chew gum at the same time. It turns out initially it seems like an odd thing to ask, but it's an easy thing to do. A lot of folks walk and chew gum. A lot of communities, clinical community partners can address care and social determinants of health, especially when we focus on specific populations and specific social needs. And again, you can see in the examples I provided earlier how those solutions now can be represented on the 3x3 along levels of intervention and again, levels of prevention. So this is a helpful way to map out the current existing interventions. Some questions we get sometimes are is this the current state of solutions that are available, or is this a wish list? And what we recommend is to take it in that sequence, to identify current existing solutions first, because that leads to some of the most aha moments for a lot of stakeholders on the clinical and the community side. For example, in some of our partnerships, what we found is that there's some cultural blinders that have prevented, for instance, hospital partners from understanding that there are already existing solutions that exist in the community but have previously been invisible to them, right? And this process of mapping existing solutions first is a helpful way to fill out this 3x3. In doing that process, you can then map out, of course, where the gaps exist and identify if there are desired solutions that are available in the broader community, in other communities, that you can borrow and steal with attribution. So that's the process of actually going through how to map out existing resources and opportunities using this framework of the Upstream Strategy Compass. But it's not enough to just map out barriers and solutions. We now need a strategy to address them, right? To implement these solutions in the first place. We call these early wins. And these are early wins not just for one organization like a hospital or a clinic or just a community-based organization or public health department. These are early wins that are by definition cross-sector, that are collaborative, joint early wins that both sides can claim as victories. Meaningful victories that are aligned with their strategies, aligned with their priorities, aligned with their own needs based on the beneficiaries they serve. So let's see what this looks like. What this really means at a high level is about making a choice as partners. How do we as clinical and community partners working together identify the solutions that we really want to lean in on together to be able to move the needle on outcomes for our population, while also building up our own capability, our own confidence as partners to be able to move upstream, to do this work, not just for this population, but down the road for another population and for another social need. So, for example, in this illustration here, a hospital and community partner, for example, a food bank and a public health department, for instance, in a particular region might say, well, one early win that we want to motivate action around is to reduce hospital use among patients like Mrs. M using food and income support. They might also identify another early win to make sure that they're balancing their portfolio of early wins across different levels of prevention and intervention. For instance, they might look at ways to subsidize vouchers or hire a financial counselor. And in this case, actually, which it should say for employees, not for patients necessarily. And lastly, look for ways to achieve early wins in advocacy and policy change by advocating for an increase in local supports. These are a way to essentially pick out literally the boxes that you want to work in, the spaces you want to swim in as you move upstream, so to speak. And this is a clear kind of first step at choosing how you're going to strategically start to make progress upstream. It's also helpful to understand that what follows is role definition. We often see in a lot of conversations, especially on the healthcare side, but even among community partners in public health, a lot of arms folded. People who lean back on their chairs and say, well, you can't ask me to take on this extra stuff. This is not within my scope, right? I'm a doctor, I'm not a social worker, I'm a hospital, I'm not a poverty agency. Those are valid, reasonable kind of questions, but they often belie a deeper disease, a lack of unease, I should say, with whether it's their role or not. What we find helpful is to be able to say, well, if you've picked your early wins, the good news is you don't have to step too far outside of the bounds of what you're already doing. You just have to identify where you're going to lead, where you're going to partner, and where you're going to support as clinical partners. So as a hospital, can you lead your tertiary prevention work because that's where you are? Can you partner with something that's at an organizational level? And can you support things that are happening at a primary prevention level, for example? And conversely, where can the community partner, the food bank or the public health department in this illustrative example, where can they lead? Where can they partner? Where can they support? At a high level, this helps, in our experience, at this stage in the kind of development of this move to address social determinants. For a lot of folks, this is, it's surprising to us that this is actually still really helpful, that just simply clarifying roles at this high level helps to unfold the arms of the folks in the room, right? Allows them to lean forward and rather than just being disengaged and uninterested in ways to be able to participate. I should point out a couple of quick things here. The bottom left work, this is what's occupying a lot of energy, research, innovation right now. This is the hot spotting work. The bottom left is where we're seeing a lot of focus on the business case, especially as hospitals and health systems come to the table looking at how they can bend the cost curve and improve outcomes for high need patients. We're proud to share this information about something that many of you may have heard about about 2 weeks ago when the Commonwealth Fund released this ROI calculator meant specifically for high need, high cost populations. I'm proud to say that one of HealthBegins' senior fellows, Victor Tabush, a professor emeritus at the UCLA Anderson School, was the developer of this calculator. It's in beta mode right now. Highly encourage you to go and look at that site. You can see the URL on the screen. It's one of the tools that's now emerging across the series that can help across the series of different early wins to be able to now calculate out the business case. These are still early days, I think, but there is progress being made in the provision of tools like the ROI calculator to help us figure out how to make the business case. Lastly, in the last minute here I'll spend before turning it over to Q&A. Once you've identified your early wins, now how do you achieve them? And from our perspective at HealthBegins, this is where some of you may have already heard us in prior webinars present our roadmap to achieve early wins, which is a get ready, get set, and go approach. Get ready means assess your organizational capabilities. Get set means to be able to really put things in place for your priority population and for your social need target, so that your clinical and community partners are now really optimizing your workflows, identifying the relevant data that you need, and identifying the roles and responsibilities of your respective team members to be able to advance your early win. And then go means launch a upstream quality improvement campaign. This is an upstream capability assessment. I'm going to skip past that and actually just make the last point here about what we mean by an upstream quality improvement campaign. To note that in previous webinars, if you're ever interested, we've spoken about the upstream capability assessment, and feel free to contact us if you're interested in learning more about that. The upstream quality improvement campaign framework really is something that we've been working on a lot because we've seen this to be successful. We've seen a campaign footing to be successful in addressing some of the really core essential needs to identify actionable measures and data, to refine these workflows, to engage champions. But it's really kind of important to communicate why we pick campaign intentionally as the word for this and not just a project. We choose this because when we're in this space moving upstream, I think our opinion is that campaigns are often more necessary to build capability than just focusing only on projects. Because projects are usually just confined to one organization. They're often non-controversial, as you can see in the left here. They're often focused on individual services. A finite group is responsible for them. All the stuff that all of you know, all of us know projects, we do them well, or we try to. That's not going to move the needle on being able to move upstream. It's necessary, but not sufficient. I think from our perspective, the work that's exciting and that's necessary here is to shift towards a campaign footing, where we're engaging not just one organization, but multiple, and engaging members of the community specifically, where we're looking at not just individual services, but looking at changing social norms or institutional practices, changing even the culture of our organizations as we collaborate, where we anticipate and predict that we're going to see opposition, both internal and public and external opposition, because we're changing policies and norms. And that as a campaign, we're accountable not only to our own stakeholders, but to stakeholders in the community, including the beneficiaries, the patients and clients that we serve. A campaign encourages the development of new leaders instead of just depending on existing ones. The campaign footing is what we found to be successful oftentimes in being able to take those early wins and help move them upstream. And when we do so, we can see how we can use quality improvement mechanisms like this example of a upstream QI campaign set of targets for Mrs. M to be able to move the needle. We've seen in a lot of examples in our work how a quality improvement framework, and especially a quality improvement campaign, can be effective in helping to mobilize clinical and community partnerships to success. This is a representative example from a public hospital system in Alameda County where we engaged with a really large ambulatory practice site to be able to improve their approach to food insecurity. So that's our approach, and how with the support and the partnership with Mark and the folks at HASC, and with a number of people across the country that we're privileged to work with, how we see a path to move upstream to achieve the quadruple aim and to improve equity. In a few minutes left, we really invite any questions.
All right, we do have some really good questions that have come in from folks. And for starters, let's just make sure we all have our essential terms in agreement. One person asked if we can define population health, which is an important concept to have really pinned down. And this kind of dovetails with a comment from another listener that it's important not only to eliminate barriers to health, but also to promote community strengths. So with that in mind, Rishi, could you give us your quick shorthand definition of population health?
Sure, I'll give the definitions that I found useful that others have actually developed, and so we can't take credit for it. But we found a couple of really helpful definitions out there. One, a definition of population health of what is called total population health comes from David Kindig and others. I highly recommend you Google and David Kindig and population health, and you'll see his distinction. And that total population health definition is something that encompasses wide geographies, multiple different stakeholders within a total population health strategy that should engage clinical and community partners and public health, et cetera. There is population medicine, as Dr. Kindig has described. Population medicine is the work oftentimes in healthcare that we term population health, but population medicine, in his definition, is the work for defined populations to be able to, for instance, improve outcomes among a panel of patients in a clinic system or among a cohort of members for a health plan, et cetera. So total population health, I think, is a broader set of terms that relies on multiple stakeholders working together. Population medicine is a helpful distinction sometimes. There is another framework from referenced earlier from the Pathways to Health Population Health Framework that the IHI 100 Million Healthier Lives campaign has put out recently, and certainly recommend that folks take a look at that. That's a really helpful set of definitions too.
So let's delve into the work at HASC a little bit. Judy has asked us, are there efforts to create an integrated care plan that can be shared by all partners providing care? Mark, can you tell us a little bit about any work you have going in that direction with Communities Lifting Communities, and as well, just what you may be seeing in that regard in the field overall?
Yeah, so I'm going to use a football analogy, so apologies to any non-sports or football fans. That's the goal line. I think the integrated care system and integrated care plan across the region, but we're on the half-yard line at the other end of the field from getting there. I mean, it's just that's the end game, but there is so much that needs to happen in order to make that a reality. And even, I mean, we haven't talked about it plays a role here, health information exchanges. And we're a long way away from seeing those become a reality as well. So that's my dream. That's where I want to see us get to. But and we've got a lot of work to do. You know, there has to be a lot more alignment and coordination amongst the various stakeholders here to make that a reality.
No doubt. And another person was interested, this is a related question, how can medical schools get involved in those focus areas that you're working on with CLC?
Rishi, you're the medical school graduate, so you have an inside view. I think it's going to happen as we talk about population health and total population health and population health medicine and community health. These are all discussions that we weren't having around our board table 5 years ago. And so a lot of you who I know that are on the call have heard me say in the past, this is very similar to the quality and patient safety journey that we as the association embarked on 20 years ago, when we really didn't talk about quality and safety. That was more left to the physicians. But over time, and for very apparent needs, we started talking about it at the forefront, and it became something that is now discussed at every hospital governance meeting, I would assume, and if it's not, it should be. And I believe we need to get to that same place with community health improvement, and I do know hospitals that are moving in that direction. So Rishi, you've got the insight from a medical student perspective in terms of what you think is going to take to get them to the curriculum to change.
Yeah, it's been a while since I've been a medical student, but I'll try to speak to just build on your points, Mark, which were spot on. I think that the work that HASC is doing with CLC and the work that all of us are, those of you on the line who are engaged in advancing efforts upstream, those represent teaching sites, opportunities to be able to teach the next generation of not just doctors, but nurses, social workers, et cetera. Especially when it comes to the intersection of quality improvement and the social determinants of health. The other opportunity really quickly is to have a bidirectional kind of flow. The leaders that are engaged from the community and oftentimes in these partnerships represent the future faculty that should be informing the next generation of our leaders. So instead of having students from medical schools and nursing schools come and participate to learn about what this looks like on the ground, especially in an upstream quality improvement framework, there's opportunities for the community health workers, the social workers, the care navigators, the hospital administrators, community benefits leaders to be on faculty or to help teach these places, the next generation as well. They can come to us, or we can go to them when it comes to medical schools in the community.
More really good questions that you're asking. We're out of time for today, but we would love to continue this conversation with you. So please keep an eye on your email inbox. You'll be getting a copy of the recording of this webinar. You also may find some answers to the questions you've asked on the HealthBegins blog. You'll also be seeing popping up on your screen momentarily a couple of survey questions, and we'd really appreciate it if you could take just a minute to fill those out to help guide us on what you thought about this webinar. Thanks again for joining us today, and we hope to see you again in next month's webinar.